Good morning. Welcome back to the lectures here. I hope you enjoyed the series of lectures you had so far. So far we looked at the IT, digital and the overall impact from certain perspectives which kind of cut across domains. We looked, I guess we looked at things like privacy and how algorithms might work or might not work, and identity and data itself. So now we'll look at it from a different perspective. We'll take certain verticals or domains where IT is used or can be used and look at issues both from the standpoint of how IT can help, how IT can make a difference, and also what we have to be careful about or what are the possible larger issues that need to be taken into account. It's not purely a technology issue. So we will focus on healthcare in this session. Like I mentioned briefly yesterday, I also am part of the eHealth Research Center. So we have a center here where we look at how look at research programs in the area of how IT or ICT in general can help healthcare. We have lots of issues in healthcare. Healthcare is a huge complex area, and we are trying to analyze that from different standpoints. So my talk will be more on kind of where IT is there in healthcare today, give examples of that. It's a huge topic, a complex area, so I'm going to only sort of sample around. And we'll spend some part of the time on looking at who can benefit from IT in healthcare, and spend a bit of time in the second half on public health specifically, because that's a large area in need of a lot of help in some sense, and we'll look at how IT is being used there and what directions it could have. And one of the core issues that are going to come around when you talk about IT and data in healthcare is the whole notion of privacy, confidentiality, security, which we have looked at a bit. We look at it from the standpoint and the nuances that healthcare brings in, and possibly what are the solutions that could be out there. So that's the broad agenda. Please feel free to stop me and ask questions as we go. I have a lot of slides, but I'll run through them and focus on a few of them as we go. So when we say healthcare and IT, who are the players in this is something we should think about. Who all can benefit or who all can use IT, who all are using IT in the current context. So if you think about healthcare, what are the different types of entities, the kinds of people who might be using it? Right? Insurance, hospitals, patients of course, health workers, government,
the banks, whether to give you some loans or not.
Okay. Yeah, that's possibly on the edge of it, but yeah, that could also happen. Corporates in general, companies working in the healthcare space. Right? So actually it's a very complex ecosystem, and if you assume that the goal of healthcare is to improve health of patients, or ideally avoid having patients at all, but let's say there are patients, we have a lot of players who come into play in working on improving the health conditions of patient or patients. And a patient probably directly deals with doctors, hospitals, and the family caregivers who are also important in this whole chain. But you definitely deal with labs, you deal with insurance companies, and as you go out, there are probably more indirect interactions that you have with people who are part of the system. So you have the hospital, administration of the hospital, you have pharma companies who are doing research to come up with new drugs, device manufacturers. Increasingly we are seeing many health devices coming up. Of course, we always had the large CT, MRI type data, but increasingly we are talking about wearables that can help health-related conditions. And various research institutes are looking at health from different standpoints. It could be policy type issues, it could be drug discovery, it could be diagnostics and so on. And medical colleges who are doing research and doing capacity building, who all need some information about patients. All this works because we understand patients, or we try to understand patients and try to work on data that we get from patients. And that ultimately is what helps improve the overall system, or that's at least what I would say the promise or the hope is. So we look at eHealth, which is one particular perspective of health, and very broadly we look at healthcare where any of the ICT technologies are used in the delivery of healthcare. So there are many different aspects of this. One is just collecting patient data. You have to collect data, organize it, analyze it, do various activities based on that. You analyze it both for diagnostic and predictive things for the patient itself, and then larger analysis, which could be more to look at public health, epidemics, and those kind of things. Devices are being manufactured, and there's a lot of hardware, software that goes into them to make them meaningful in the healthcare context. So the imaging devices, the sensors that get created, and how you convert all the data back to something that can be used. At the higher end, we're increasingly seeing devices that will help make surgery better, all the way up to robotic surgery or surgical robots itself. And so all these are part of this IT ecosystem that we are talking about, or that we will use as e-health broadly. And ultimately, you need hospitals and other entities through which healthcare is delivered, for which you need to manage lots of information, lots of data, and so on. So all this is part of what would be considered. So you could pick any one of these and spend days on it. So we'll try to kind of do a broad brush work through these. And I should also mention assistive devices, devices that could be for disabled or people with certain motor and other kinds of conditions, which are helping them do better overall. And technology, in the sense of information communication technology, is used heavily across all these, and that's where a lot of research and focus is happening. So if you focus in on a patient, what we are trying to collect is data about the patient, the medical records very briefly, the history of the patient, to do meaningful analysis or meaningful healthcare, meaningful treatment of patients over time. You need as much of the historical data as you can, otherwise you're doing very local symptomatic treatment. So ideally, we would have longitudinal data for a patient that is over their entire lifetime. We want to capture all kinds of information about illnesses, diseases, immunizations that they might have done, anything to do with the development history, allergies, medications, and broadly maybe even social habits and even family and other environment. All this is part of the data that is needed to make eventually a meaningful, holistic decision about the patient. There's also demographic data having to do with their where they live, age groups, lots of other issues that come in. Now, while this is at a broad level, there's a lot of data that needs to be collected. By the way, a lot of this data is being collected maybe on paper today. So it's not that this is new, right? It's just that we are saying if this moves into the digital space, how does the complexity come in? So when you go meet a doctor, what's typically called a medical encounter, you have information about who are the people participating, at what time, what location, those kind of things. But the list of symptoms, complaints, examine what was found, any tests that were done, the results that came out of the test, and finally what's the diagnosis, and then a prescription or a treatment plan or something. All this is part of the record of a patient. And typically today, by and large, this is done on pieces of paper. They are either kept in the hospital or the clinic, or when you leave, they give you a prescription or a discharge summary or something where some summary of this is there. Obviously, it's very obvious that that is not a sustainable or scalable system, because it depends a lot on those pieces of paper being around, and that they all get integrated the right way, which if the registers are sitting in different buildings, different hospitals, and you can maybe lose some of the papers you have, then your history is never complete. So that is a basic challenge which comes in the way of large-scale, reliable healthcare. And so one of the big focus of e-health is to say, how can we manage that better? And now we also have a lot of patient-generated data. We always had patient-generated data. You would go tell the doctor that yesterday morning I had fever, yesterday night I had something, and all these things. Now we have devices that will help us gather this data at a much finer granularity. And so there is a lot more data coming in patient-generated, which also has to be added, which is meaningful in many contexts. Right? Ideally, diagnosis should take into account all pieces of data that's there, because you don't know what the real clues are. Medicine, by and large, is data-driven. It's evidence-based, or of course, sometimes experience-based, but experience comes from looking at lots of cases. So ultimately, the practice of medicine involves dealing with lots of data. The setting of the medical encounters, if you might call, because doctors have a very limited time they can spend with you, there is maybe they have over time, with practice, they figure out what is the right set of data to look at to treat a particular condition. And it may be not data that's explicit, it could be data that's implicit. Your look on your face, the way you walk, all these can be clues for the doctor to decide a diagnosis. But obviously that works better if the doctor is more experienced, and works less if the doctor is less skilled or less experienced. So those challenges come in. Right? So The data itself is coming from a variety of sources, and from a technology standpoint, we need to understand how the data is sourced. So a lot of it is manual entry still. Even if the clinics have sophisticated equipment, some of the things still has to be entered either by typing into a keyboard or writing in paper or somewhere. One of the biggest places where data has been used and collected is the whole thing around imaging, starting from X-rays to MRI, CT, PET and so on, where you're collecting large amounts of intricate data about the anatomical details of patients, and then having a structured way to store it and access it. So there's different heterogeneous kind of data that we need to deal with. Sensors and the smart devices we talked about, they're bringing in more data in real time, and probably each sensor or each set of devices generating data in a different format and different sequence of time. Labs again are all about analyzing samples and coming up with some information about them. You get a hemoglobin count, or you get a creatinine level count or something. These are numbers that come out at the end of it and become part of the database of each person. And so the big challenge is that these are all collected by different players at different locations, at different points in time, in different formats. And you still have to make sense of all this the next time you go to the doctor. So it's clearly a challenge, and we are probably quite a far way from making it really ubiquitous and consistent. So the challenge with this is that we have what we call continuity of care. You don't always go back to the same hospital or doctor every time. Over a course of your lifetime, for sure, you would go across many different kinds of entities that deliver health care. And obviously, in the current environment, they all don't have access to all the data that you generated, that was generated about you, because especially if it's paper-based. And even if it is not paper-based, and if it is in some health record system of the hospital, these are typically silos. A given hospital or a hospital chain might have a database about you, but that is not necessarily easily accessible or shared with a different hospital. So if you as an individual have to move around, and this obviously the history is, your longitudinal history, it has to be consistent, it has to be used throughout. How do we bridge this problem? Clearly there is a need to integrate all this different data, and the whole notion of what are called electronic health records or EHRs is trying to address this problem, and especially what we will call a shared EHR or a.
So are we talking about the scenario in India specifically?
I'll get to that. I think the
problem is worldwide.
Problem is worldwide. I'll talk. It's not any better in other countries, right? I mean, so India is clearly much behind, both in the urban private health practice as well as in the public health for sure. So in the private, the larger corporate health practice, they have started putting together EHR type systems that at least span their network, but they don't necessarily talk across networks.
Even corporate hospitals also, they are not falling in line with the global scenario.
Well, global standards are emerging, so they are also trying to fall in line with that. We'll talk about that, about standards in a little later. In the public health sector, which I'll focus on a little more, there is almost no data of this kind. It's on paper. I mean, the data is there, but it's on papers and registers, and each hospital maintains, each center maintains. Globally, I don't think it's anywhere near a solved problem. Every country is struggling with this to different extents. Countries that have consolidated or universal healthcare, like countries like UK, have developed more global systems. Countries like US, where it is distributed, are also struggling with this, right? So typically, as long as you stay within a network, you're okay. The minute you go out, data gets lost. And there's also a lot of questions about what data actually gets entered. So while there are hospitals in India that use systems of some kind, it is difficult, as we'll see in a bit, to enter all this data in a consistent way. So the solution often is to not enter data. You enter only the critical data that's needed to do some level of continuity. So continuity of care as a concept is probably one of the most important things that will need to be addressed, is being addressed. And it has different manifestations depending on whether we look at a urban type of setting or a rural setting, in a public health type setting. Maybe we'll, so you can probably relate to this in, okay, I'll come back to this later maybe. Right? So we can say that what we are really looking at is to have a patient-centric database, a patient-centric data, which is the lifelong health record. Everything from birth, or preferably from conception to death, and maybe data kept beyond death also, because it could have ramifications for the family and other analysis later. And the challenge here is there's so many different aspects of healthcare that we have to deal with. There's so many different specializations that we need to deal with, and therefore we need to have a way that all these different views of data can be managed. If you have an eye issue and you go see an ophthalmologist, they don't necessarily want to know that you fractured your leg last week, may or may not, okay, and vice versa. The orthopedist probably needs to know your vision is bad, but not maybe the other way around, right? So these are very tricky. It's very contextual, and given the quantity of and the variety of data, you don't want to dump these on the doctors, because then they will have it's noise. There's too much data as noise, right? So one of the big challenges is how to organize this data so that it can be used appropriately at every point of interaction, and that is difficult. And part of that will be, since the thing is so heterogeneous in how the data comes about, how do we agree on how it should be stored? What does it mean to store blood pressure or temperature? When you say temperature, do we store it in centigrade or Fahrenheit? When you say blood pressure, do we store it a certain way? So right down to that level of detail, there has to be standards and agreements on how data will be stored so that sharing can happen, so that ultimately we get better care. So, and if you have standards-based storing of data, you can start thinking about applications that can work, which are somewhat independent of the exact database or health record system that you're working. Right now, there's a lot of vertical integration, in the sense that you can get fancy systems, you can get elaborate systems that can manage all this data, but then you can only run applications that are done on that, preferably by the same company and so on. So it kind of narrows the spread of these things. So there's an organization or an initiative called OpenEHR, which is trying to address this. It's an international entity that is putting together a set of standards for health records. So it's OpenEHR. The specifications are open. It's done by a community across specialists all over the world, and it's trying to put together a architecture, a specification, architecture, information model, security model, and other things that will help make a EHR workable and shareable and interoperable.
It doesn't make use of standard storage methods like relational database and something like that.
The intention of these kinds of standards is to abstract away from those. So it doesn't matter whether it's a relational or non-relational, so long as we can provide a certain view for different users. That becomes more of an implementation issue as against a specific.
Those methods are, irrespective of the type of data, it's for universal approach. But here that you want to follow separately another. So that means there's a deviation in terms of standards.
No, the standard, these systems are, I'll get they're very detailed in terms of standards. So, but at the lowest level, whether you use a relational database or not is a decision that will be defined by your size, your need for performance, and so on. So if I have a small clinic and I have an OpenEHR based system, it doesn't matter what database I run there, so long as I can let it interact with other systems. So the architecture is defined with sharing in mind. So you can have different instances of EHR at all these different places, but they all conform to the OpenEHR specification, and therefore they can collaborate. That is the promise, that is the goal that we are driving towards. So this is one big, OpenEHR is probably at this point the most significant one, but there are many such initiatives. There are many proprietary initiatives that have happened over time and so on. And this is relevant again in our context of public health. I'll try back to that. So there are a lot of, so what the summary is that if you have an integrated EHR, or you would rather say that you need an integrated EHR to be able to improve various things about healthcare. How do you reduce errors? How do you get access to information as and when needed? How do you make sure patients don't fall through the cracks, slip through the cracks? How do you make sure that we don't keep doing the same test? Right now, you might go to a doctor, they might do a test, but that's kept within the hospital, and you move to another hospital for a second opinion, they might ask you to do the test again, depending on the kind of test. So that's clearly a waste. How can we start looking at analyze this better so that we can start making better predictions about risk based on risk factors and things, right? Which is, so we'd rather avoid the disease than handle the disease, right? So it should go into managing the whole scenario. Decision making using complete data is probably one of the most important aspects, and later when we talk about ML and related things, this is becoming a big issue, is that just the sheer quantity of data and the variety of data that a doctor needs to process in a very limited amount of time is becoming more and more of a challenge. And so we need systems based on access to a lot of data that can help the doctor make in the decision making.
This decision making, to what extent the subjectivity matters in terms of decision making in such things? It is totally away from being subjective.
No.
To some extent it is.
So medicine is evidence based and experience based. So it is a combination of objective and subjective analysis today, right? What doctors practice. So what algorithms will do is, as you would have heard in the thing, to whatever extent they are programmed, they intend to be objective, but they are as good as the data or the programs that have been fed into them. So they're not subjective in the sense we would normally think, but they can be probabilistic. So a lot of it is about how to make the treatment of the patient better, how to make the diagnosis better. The other part is, especially in public health, you run large programs. You're spending a lot of money on public health. So how do we know what are the effectiveness of these programs? How can this data help identify, manage, track the effectiveness of this program? And at an overall level, both from a patient health standpoint and cost standpoint, how do you prevent readmissions? How do you prevent, reduce the amount of hospitalization, which is a big issue. If the treatment is not done or the follow-through is not done right, readmissions happen. So all this would presumably improve if you have a good EHR. And so we can say that at a very high level, we have a set of collaborating EHRs. Data is accessed and added to any one of them. Various entities access this data either for clinical purpose, research purpose, or other program type purposes. And over time, we have more interesting analytics that can be applied to this, which would include just basic data analysis to machine learning and other things, so that we can get better systems, better reports. So this is the direction that a lot of healthcare focuses, research in healthcare. And the core point would be that this is patient-centric data. We are getting all the data in an organized form about patients, because most of the time in treatment, you are interested in data for one patient. It's only occasionally that you look at things across patients. It's slightly different from normal databases that you might deal with. So, but of course, with research and other things, the cross-patient information becomes very important. So both need to be managed, and that's why individual view of data as well as aggregate view of data has to be done. So these are challenges in any database data modeling issue. They're not straightforward. And since we're talking about distributed data, we're talking about data that's distributed across multiple instances of EHRs possibly. Imagine you go to completely different hospitals. They will maintain their own data. But somewhere we would also hope that these all get aggregated in the cloud somewhere, so it's abstracted away from the endpoints of the usage. And that makes the whole, that at least has the promise of patient mobility, that you can move from place to place and have access to your data, and therefore we get continuity of care even across geographies. This problem is very important, very serious from many different standpoints. Any of us could at any time be in any part of the world and need access to medical data, and you would need access to your health records ideally. You might be in a situation where you're not able to, you might be unconscious, right? You might, and they still need access to the data. So challenges are pretty large. And when you get to public health, which is much more distributed in some sense, these issues become much more challenging. And we'll look at that. So while this is a sort of the high level concept, a long way from being able to implement it consistently across. We have lots of issues to work with, because once you start making data available, public patient health data available, privacy and security become like the top issues. Health data is of high, as you would have heard yesterday, the personal information, sensitive personal information that we have classifications in our IT Act, put health records as one of the most important things. Right? So there is a huge issue around privacy, security, confidentiality. But at the same time, you want access. Like I said, the scenarios that you have to handle are very complex. You have to go to a pharmacist and get a medicine. You have to show some kind of prescription, and let's assume everything's electronic. The pharmacist has to have access to the prescription part, but not any doctor notes, because that might indicate something about your condition. As I said, you might go to a particular doctor and you want part of your data to be available. A lot of people, if you look at health data, you have all kinds of health data, and mental health is one of the issues. So in general, mental health data is protected or needs to be protected much more, because there's lots of social stigma and other things associated with that. A patient might go to a doctor and may not want his or her mental health data to be exposed. That adds lots of complexities. And like I said, interoperability is a core requirement because we are going to go to a diverse set of entities who deal with our health data. And all this data better not be lost because we are saying this data has to last throughout your lifetime. So persistence is a huge issue. And cost and connectivity and scale and other things that we can discuss. How do you make this work for 1.2 billion people? If you think Aadhaar was a difficult problem, that's nothing compared to this, because there we had to store a small amount of well-structured data and protect it, right? Biometrics and some demographic. Now we are talking about potentially gigabytes of data per person. Every MRI could be a gigabyte of data, potentially even terabytes for a chronically ill patient, and still have all the controls that you would like around it, going back to not just privacy, but also how do you access it? How do you do it in low connectivity areas and so on? So challenges are huge. I think there are initial work towards many of these things. It will probably take a few years to fully develop. But while those are being developed, all these other issues are also being addressed or have to be addressed still. And these are more from a technical level. You can also look at the same thing from a policy and other levels, especially when you talk about security. Make sense? Any questions? Okay. There is already some amount of health information system around. Pretty much every hospital has a system where at least they will do your billing right. They'll make sure that you pay for everything you do, or that you will not get services unless you pay for something, right? So typically the administration side of it, because that is more like maybe any other enterprise, has evolved quite well. So we have these hospital information systems, hospital management systems, which manage, I would say, the non-clinical part of health data quite well. And the focus has been on broadly making sure that the hospital runs as an enterprise. Revenue, billing, inventory, HR, those kind of things. So they are not very different from other enterprise systems, and so there have been many, and by now many hospitals, definitely many of the private hospitals are, and the public hospitals I should say, have this in place. In some cases they integrate to the EHR, or they might have a kind of EHR wrapped into them, but that's I would call a very basic EHR. At least it would have high level information about the symptoms and the diagnosis more than the symptoms, so that you can bill correctly, right, or do other things correctly. But the goal is now, how do I integrate HIS, HMIS with an EHR so that actually everything gets connected? So in a hospital, the workflows are automated, maybe through a digital system. The patient data is still on paper. So you'll find nurses typing into the thing and then carrying a register to the next, right? So you have two systems. So eventually these have to get integrated, and then we can say that the whole healthcare team that's working on you is integrated, including you. And that's still a holy grail at this point. Okay. So if we'll just sort of stop looking specifically at healthcare, we have to health records. We have to say that we want the different issues that come up are, how do we store them, what is the repository, what is the methodology, what is the standards we'll use, what's the format we'll use to store it in one place. How do we ensure interoperability across different health systems? And there are lots of standards in the healthcare, because healthcare is serious data and there's lots of healthcare. So there are standards relating to how you will define, how you will classify a particular illness or condition. So SNOMED CT is one of the world standards for that. So it will be able to specify, you'll have a standard way of specifying every possible illness or condition that is there. But because it's trying to do all that, it's also very complicated. You have standards relating to how data should be shared, and specifically about what are the formats of the messages, what is the encryption, what security, and so on. And this is where things like HL7, FHIR, and so on come in. These are well documented, well practiced standards. They've been around for many years. And any system that, in India we don't have such strong regulations in place, but for instance in the US, if you're going to use such a system, it has to comply to all these HL7, HIPAA, and other things that we'll talk about. The other challenge is, while we can do all this for one system, how do we ensure interoperability across systems. So in health is typically a state subject. So the state manages a lot of things, even in public health. There is no necessity to share it across state boundaries. Even in the US, because of insurance and other things, similar things happen. So how do you still exchange information across whatever boundaries that are there for commercial or geographical reasons? And so this health information exchange is another whole set of standards. So it's a huge number of standards that have to be looked at to actually put such systems together. But then we want to share data, so what are the privacy and security issues that will come in? You have data at rest, data in the database, which is open to attacks, which is open to hacking, and you have data in transit, which is moving intentionally from one place to the other because you want data to be accessed at different sites. And then, back to the question of scale, distribution, and so on. So, just to go back, so data in healthcare is not new, managing of data is not new. So the whole evolution of digitized imaging, starting with X-rays, CT, MRI, PET, and so on, is all about collecting essentially X-rays of your body at different levels of resolution and being able to analyze it visually at least. So you have MRI machines from which you can, depending on the kind of analysis you do, you get very detailed information about the structure, anatomical structure, as well as behavior of different parts of the body. So this has been applied very successfully to understanding individual anatomy, in whether it's heart conditions, cancer, bone and other orthopedic issues, and so on. And it allows doctors to get a very realistic view of what is inside the body before they do any surgery or anything. And this has become now commonplace in medical practice. So this has moved along well, and in this case there are standards like PACS and DICOM which define how data will be stored and shared. So there is a working system, and it is possible today to have data stored in one hospital and access from anywhere, so long as they can work out the protocols about who should access and why, and the data will actually be by and large usable by the other doctor.